Minimizing the internal incision in the abdomen can decrease donor site morbidity. Not all patients are suitable for this.
Transform the so-called day case DIEP flap.
The cost difference is massive. It sounds like science fiction, but it probably will be the case in a decade.
Hello and welcome to The Rest is Plastics, the podcast to the Journal of Plastics, Reconstructive and Aesthetic Surgery. I'm James Chan.
And I'm Anton Fries.
So DIEP breast reconstruction has transformed the lives of thousands of women across the world. It's reliable, reproducible and very well established. But can we make it even better? Well, today we are joined by Dariush Nikkhah, a plastic surgeon based at the Royal Free Hospital in London and Associate Professor of the University College London. His paper is on minimal fascial incision to improve donor site morbidity. Welcome, Dariush.
Hi, thank you so much, Anton and James, for inviting me to your podcast. Great honor. Good to be talking to Anton, based in Texas, and then James, you're in Buckinghamshire right now, aren't you? Cool. So, this paper, actually, one of the inspiration to this paper was one of the senior authors, Shadi Ghali, visited a colleague and friend of ours in Texas called Sean Boutros. And he actually does a lot of DIEP flaps for cosmetic reconstruction of the breast. And to get patients home very quickly, he does this short fasciotomy DIEP. This technique has actually been described in Korea and also in the US as well. Minimizing the incision in the internal incision in the abdomen can potentially decrease donor site morbidity, enhance patient recovery, and get patients home faster. But there's very few papers in the literature that actually talk about how to do this, because there is a learning curve. And in the paper, we talk about the instrumentation needed. You need a good headlight, long Langenbeck retractors. We use them from the renal transplant set. And also patient anatomy is important as well. So not all patients are suitable for this. I think we come up with a scoring system as well to help guide surgeons who want to do a short fasciotomy DIEP. And we called it the Hampstead score, which one of my registrars came up with. And I think that could potentially be helpful in those who want to do robotic or laparoscopic DIEP as well. So short intramuscular incision makes it fairly straightforward to do the dissection. There are some difficulties when you want to get a long pedicle. So I thought Anton does quite a number of DIEPs. So when we started out, we were doing much bigger incisions and sometimes dissecting on the lateral side of the rectus to get as long a pedicle as we can. But that can denervate the rectus muscle, and some patients can get Spigelian hernias, even if you put a mesh in. And where I trained in Queen Victoria Hospital, we would put a mesh in pretty much every single flap reconstruction. But potentially, if you use this technique and the patient has suitable anatomy, you don't need to use mesh. And this is a small study, but there's a significant difference in using mesh with the standard incision versus the short fasciotomy incision. But there are some pitfalls. You need to obviously look at the scan and identify a suitable perforator which is large enough to accommodate the flap. You can do this short fasciotomy incision on both sides, so do a bipedicled flap as well. I think this is something that I offer to some patients. It's not suitable for every single patient, but it's something that I think we're trying to introduce into our practice since we published it.
And Dariush, so for those of us who are not breast reconstructors, the idea of this minimal fascial incision is to reduce the donor site morbidity.
Yes. So to reduce pain, donor site morbidity. I think if you make a small incision in the tummy, the patients have less pain, they can recover faster, and they can get out of bed. And, most centers in the world have an enhanced recovery program. And I've noticed in the cases that I've done with the short fasciotomy DIEP, patients can get out of bed faster, less pain, and there are some papers in the literature which fit with what we found in this article in JPRAS as well. So it's important to ask the patient how they feel afterwards, and this is probably one of the pitfalls of this paper, that patient-reported outcomes weren't kind of captured, which is one of the pitfalls of the article.
We can talk a bit about the results later. But while we're on the subject of the kind of the why, now you've mentioned the patient experience reduced the morbidity of the procedure. Clearly, that's obviously first and foremost in your mind, and Dr. Boutros is well known around these parts, and certainly what he's done is sort of transform the so-called day case DIEP flap, and part of that is your patients. It's all very well saying you can do a fast operation, but part of it is getting them out of it, is for them to feel comfortable enough to go home that day, or let alone the next day. So clearly that's really important. But there was a second reason, isn't there, that you alluded to, and that's the sort of the next steps of DIEP reconstruction. So can you mention a bit about that?
Yeah, so this is kind of a prelude to laparoscopic and robotic DIEP. So we did a series of laparoscopic DIEPs, and we did this with a general surgeon who is experiencing hernia reconstruction. And we went in a plane which was extraperitoneal. We put a balloon in, and we made short fasciotomy incisions using this technique. But the problem with the laparoscopic techniques is you don't have the degree of freedom of movement, and it's quite difficult to do as a plastic surgeon if you don't have laparoscopic or general surgery training. Recently, we did the first robotic DIEP with the help of Jesse Selber. He came in virtually to give us some support. Myself and a general surgeon called Alistair Slesser, and an amazing team. So with these kind of first cases that you're doing in a department, always have a good team around you. So we did a robotic DIEP, and we found that obviously this kind of hand performed minimal fascial incision is very crucial for you to know before going on and being able to do a robotic DIEP. I think I mean, this is my personal thoughts, but I think that probably the hand performed minimal fascial incision is very comparative to the robotic DIEP. The only difference I would say is that in the robotic DIEP, if you go in the extraperitoneal plane, you can clip the pedicle under much better control, and you don't need an assistant holding the retractors up, and it is quite tiring for your assistant. But I mean, having a Da Vinci robot and the cost of it, the cost difference is massive. So my vision in going forward is that probably there will be some trials in the UK and probably internationally looking at robotic DIEP and hand performed DIEP with the open approach. So I mean, I think you need to know how to do this technique if you want to go on and to do robotic DIEP, and that's, I mean, we're still learning at the moment, but there's many centers in the US that are actually doing this technique. But when I recently went to the American meeting, nobody seems to have standardized the procedure. I think for a procedure or a flap reconstruction to be good, it needs to be standardized so everyone can do it. There's no point in coming up with a surgery that only one or two people in the world can do. So I don't know what your thoughts are, Anton, about this as well, or James.
Yeah, no, I mean, I think the so-called microfascial incision is fantastic, and we certainly strive to minimise the incision in the anterior abdominal wall. But but I know we'll come on to this. There's a certain amount of patient variability in terms of anatomy, and I will talk about your patient selection. Before we go into that, just talk us through the methods of the paper. So how did you actually set it up to evaluate the
essentially, I would say it's probably a level 3, level 4 evidence in terms of the paper. Retrospective design. Patients were essentially placed into two groups. The minimal fascial incision, which is less than 6 centimeters. I think the average was about 4.9 centimeters, with the smallest incision performed in the department, I think it was about 2 or 3 centimeters. And then the standard incisions, anything from 6 to 15 centimeters. And there's some pictures in the paper showing the short fascial incision and the standard incision. In some cases where patients have had previous abdominal surgery, we open the whole fascia and go on the lateral side of the rectus. So you do get a lot of muscle denervation. Fairly selective on the cases. So it was, I mean, it probably was more like a pilot study. In terms of kind of data, only 33 flaps. We looked at length of stay. The length of stay was reduced in the minimal fascial incision group to 4 days. I mean, usually my patients go home on day 3 or 4. I mean, we've got to be realistic. Some, you know, you can go home the next day or the day after, but a lot of the patients that we perform this surgery on, some of them don't want to go home the next day. And I think some of that, in the US, I may be wrong, but some of the benefits of sending the patient home on day 1 or 2 is there could be a financial benefit to that as well. So, I mean, in the UK, I think we've introduced that kind of enhanced recovery protocol that many centers have, and we try to get patients home between 3 to 5 days. The perforators, usually in the minimal fascial group, ideally just take one perforator, dominant perforator, but in some cases you can find two perforators together in the same row, or two perforators on either side if you want to do a bipedical reconstruction. And actually, in the robotic DIEP that we did last month, we took two perforators very close together. I mean, in terms of follow-up, I think our follow-up was quite short, but none of the patients encountered a hernia or bulge. But I think we probably needed longer follow-up. Some of the patients that I operated on 6 years ago come back to me, and some of them have got bulge or hernia. So I think to make meaningful kind of long-term outcomes, you probably need to be looking at following up patients for several years. And that's probably true for a lot of microsurgical procedures.
Dariush, can I just ask you a bit more about the methodology? It's great that you have a comparative study and you look at the characteristics of these patients, and none of them hit a statistically significant difference. So they seem comparable. Can you just talk us through the selection into each group? This wasn't a randomized thing, was it? Was it just a kind of surgeon preference? How many surgeons did you have doing these?
I think mainly it was surgeon preference, and also preoperatively look at the scans as well, and see if it's feasible to do a minimal fascial incision. We have 5 microsurgeons in the department, and I think most of us can do minimal fascial incision. In some cases, it wasn't feasible to do the minimal fascial incision.
And what do you mean by that? When is it feasible and when is it not feasible?
In patients where they've had multiple previous abdominal surgery, they've got a long intramuscular course on the scan. Although some surgeons like Sean Boutros say that doesn't make a difference, but I think it does. If you've got a very long intramuscular course, more than 4 centimeters, and you've had previous abdominal surgery, when you're doing this type of minimal fascial incision, you will struggle, and you can get problems with bleeding, and it's very difficult to visualize things through a narrow corridor. So that's when, if you can't see, then you just open up the fascia, and that's potentially where robotic-assisted DIEP could be beneficial. I mean, I'm not sure if there's much out there in the literature about doing robotic DIEP in patients who have previous abdominal surgery, previous scarring, and long intramuscular course. There isn't. And even the team in Taiwan, who've probably done a lot of robotic DIEPs, I think even them, they generally pick their patients to do short fascial incision DIEPs where they've got short intramuscular course on the CT scan. I mean, since we've been doing this technique, I always look at the sagittal view on the DIEP, and I don't know if Anton, whether you do this to look for whether the patient has a long intramuscular course. My radiologist, they never report that, but I always look at that because I know it'll be difficult if the patient's got a really long intramuscular course. And interesting, some groups in the UK, like East Grinstead, which probably do the most DIEP flaps in the UK, they often opt to do an MS tram if the patient's got a very long intramuscular course. Obviously, it's really important to make sure that your reconstruction works. It doesn't, I mean, if your fascial incision is 2 centimeters or 7 centimeters, the most important thing, I think, really is to make sure that the reconstruction works, because it's really precious to get it working.
Absolutely. So moving on to the results then. So you had these two groups, and you found, well, let the listeners know exactly what the results were that you found on those groups.
So results, I would say, in the minimal fascial incision group, they had faster recovery, so they went home faster, less use of Prolene mesh. So we didn't need to use, we usually just put sublay mesh in, and in terms of differences in terms of complications or return to theatre, there wasn't any significant difference. So it was safe, and also in terms of operative time, there was no difference between the two groups. Our research group have also written a paper, I think 2 years ago in JPRAS, looking at operative time and complications, and we have this kind of 7-hour window. So if the DIEP flap takes longer than 7 hours, then you do experience increased number of complications such as wound breakdown, infection. So we had that data from previously. Also, there was not too much difference in terms of the groups, in terms of their characteristics as well. Also, we looked at flap type, unipedicled and bipedicled. So we had 9 patients that had bipedicled flaps in the minimal fascial incision group as well. And the mean operative time was interesting. It was slightly higher in the standard incision group, but it wasn't significant. Potentially those patients have more difficult dissection because they've had previous surgery. But mesh was significant. You can see in the table of operative characteristics. And complications, immediate complications, there were 2 in the standard incision group, but that wasn't significant. It's too small a data set for us to make any kind of meaningful conclusions on that.
So definitely some encouraging results.
Yeah.
But of course, it's slightly confounded by your selection, isn't it? Because if you've got a short intramuscular course, so you can do the minimal access, the dissection is going to be quicker because it's just dropping through the muscle versus, and so, but that's kind of the point, isn't it? Really, that's why you're.
It's always nice when you get the short intramuscular course, but I'm never lucky. I never get those all the time. I mean, I'm not sure if there's a paper out there that shows the percentage of patients that have got a long intramuscular course on the scan, because in ALT flap we know that 80% of the time it's going to be through the muscle, a long intramuscular course through them, rather than septicutaneous 20% of the time. But I think I may be wrong, but I think in the future robotic or short fasciotomy DIEP will only be suitable for a small selection of patients. But as people become more competent, maybe they'll be able to expand the applications of robotic-assisted DIEP. I may be wrong, but that's what I think.
From what I've been hearing at the meetings, people, the robotic guys, if it's a longer than a 4 centimeter intramuscular course, and they will consider them not suitable for robotic and do a standard open procedure, and their cases are selected, even to the point of, I think, doing one side robotically and the other side by hand, which I guess that's part of a sort of IRB group.
Yeah.
But
We've done that. We did that on a patient of ours who had a laparoscopic DIEP. A second case we did, and she had an appendicectomy scar on one side, and we were raising a bipedical flap, and one side we raised laparoscopically, and the side with the appendicectomy scar we just did a standard incision.
One more thing, Dariush. I mean, when we talk about minimal minimal incision in your study, we're talking about 4.6 centimeters versus 6 centimeters. It's really just 1.5 centimeters difference.
Yeah. I mean, it varies. I mean, I think it depends on. I mean, it depends on your perforator, really. I mean, sometimes you can get away, as Anton said, with a really nice short incision, and you see in the paper we put loads of fish hooks around, and then you do careful dissection with the bipolar, and then you go beneath the rectus muscle, and then that bit of the operation, what I usually do is use a little cat's paw, and then we go to bigger Langenbecks, and then the Langenbecks that we use in the renal transplant set, and then you have to have a headlight because you look through the narrow corridor. But going back, you were saying about how can we get better data. I think the best way to get better data is through multi-center collaboration. We've published papers with a group in Netherlands recently in JPRAS Open. I think multi-center data is beneficial, and then long-term outcomes. I mean, looking at donor site morbidity. I mean, you can assess the donor site by doing simple tests like an ultrasound. I think the group in Taiwan had some really nice videos and kind of outcome measures for their robotic cases. So you can look at that. I mean, most of the patients that have this type of reconstruction, I've noticed, whether it's laparoscopic, robotic, or minimal fascial incision, I can see that their recovery is faster, and they get back to normal activities much quicker than patients who have the standard incision. But meaningful outcomes, I think you're looking at, James, probably a study that you need to follow up patients for more than a year, and that's quite difficult. The only way to do that, I think, is either getting funding. So we've got this thing called Research for Benefit funds that I've used with NIHR, and we've applied for that in the UK, so that can potentially help us. And also just collaborating with other centers. I mean, maybe with Anton's team in the US.
I'm going to run off and write that paper about the length of the intramuscular cord. I'm going to get someone to go through all my CTAs for the last 5 years. That'd be plenty of numbers. Anyway,
that's actually a good idea. And you know what you should do? You should get AI to look over it, because they had some papers at the American meeting. They were saying using AI to look at the CT scan, so you can just get AI to do it for you.
I thought you were going to say we should get AI to write the paper, but as a deputy editor for JPRAS, I would like to say that these are not the opinions of JPRAS.
So Dariush, you've touched on your experience with laparoscopic approaches and also the robotic surgery. But before we kind of pivot onto that, can you just summarize then what you think are the main takeaways for the listeners and viewers?
Okay, so I think this technique is not for every single patient. Pick the patients wisely. Look at our scoring system. That can help you. In terms of the technique, I think it's described in this paper quite nicely. So if you've found a suitable patient with a large single perforator, no previous abdominal surgery, use the multiple fish hooks, long instrumentation, because you want to go through a narrow corridor and you need a headlight. These patients, often you don't need to use mesh. You can do bipedicled reconstructions if you're worried that a unipedicled flap won't be enough. then go bipedical, and you can do that as well. It's safe as well. So I do feel that there is a learning curve to it. So you shouldn't be doing it on your first, couple of DIEP flaps. I think, I mean, I've probably done 300, 400 DIEP flaps. I'm still learning. I'm not in the same figures as the guys in Texas, but I'm still learning. But I think it's a nice thing to have in your armory as a DIEP surgeon and to offer your patients. Um, and I mean, I like writing papers that have some sort of clinical benefit or clinical difference, and that's one of the previous editors, Stefan Hoffer, said in your paper, make sure that you've got some nice clinical illustrations and clinical pictures. And I always try to do that in my articles. And I think that's really important.
That's great. No, it is. It's a great paper, and it's a great, it's a great pearl for people to, because I think everyone does these operations. As you alluded to, the priority is to get a great reconstruction, but in everything we do, we rob Peter to pay Paul, and we've got to make sure that the donor site, whether it's a DIEP flap, ALT flap, any kind of even a skin graft, we've always got to think about the donor site and that secondary morbidity, and this is exactly what you're addressing, which is part of the philosophy of our specialty, isn't it? So that's great. Just as we wrap up, you've mentioned laparoscopic, we've mentioned robotic, maybe even minimal access. Once we add everything together, the costs of each, the time, the learning curve, and this is a high volume procedure, isn't it? There are, unfortunately, breast cancer, tragically, and maybe one day it won't be. We can only dream, but tragically, it affects a huge number of people across the world. Where do you see the future of this procedure?
I mean, at the moment, Anton, the cost is too much to do everything robotically. I mean, the robot costs 2 million, the Da Vinci robot, not even the new one. If you're doing a DIEP by hand, the costs are much lower. I mean, even in the UK, the hospital cost for DIEP flap, if a patient is paying themselves, it's tens of thousands. So it's probably the same in the US. And in the US, I think I see some surgeons set up their own centers or hospitals for DIEP flap. It hasn't really happened yet in the UK because I think the finances here are not as good. But at the moment, I think in terms of cost benefit analysis and comparison, I think I would still feel that the gold standard is to do this operation by hand. And if you look in the literature, nobody's really standardized robotic DIEP flap reconstruction. I think we're still trying to find out how best to do it. And it's too expensive, I think, at the moment for the NHS. And we at the moment use a robot from one of our colorectal teams. So the Royal Free, we've got 2 Da Vinci robots, and to get space on the robot is very difficult. And there's a surgeon based in Hawaii, I think Daniel Morera. He said to me to collaborate with the urologist or colorectal team, and that's how we try to innovate and improve things. And that's one of the cool things about our specialty. We can work with other surgical specialities, which is quite fun. It makes it quite cool as well. So I at the moment, I still think, Anton, hand is the way, particularly with the high volume of cases. I mean, this month I think I've got 6 or 7 DIEP flaps, and I'm not sure in terms of cost it's going to work robotic at the moment.
Yeah, I'm sure you're right, but equally, you're part of the conversation and your group to making this sort of reducing those overheads, so that and we need to be engaged, don't we? Because clearly one day, the future of surgery probably is robotic, and I don't mean well, Elon Musk says within 3 years, but even if it's 20 or 50 years, and we've got to be part of that conversation now.
I hope, one part is that if let's say you've got the robot there, and the robot will maybe learn your movements and do parts of the procedure. I mean, it sounds like science fiction, but it probably will be the case in a decade, particularly for microsurgery, I think. So, I mean, I don't know. What are your thoughts, James? Do you think it's going to be a game changer, robotics?
Probably. I mean, it's as you say, it's patient selection, isn't it? That's the key, and to make sure that it's widely available and not just something only a few people can do.
Yeah, for something to be good, everyone needs to be able to do it. It's like the ALT flap. It's a versatile. It's a that flap was standardized by Fuchan Wei. So we need to come up with something that everyone can do, and then you know that it's a good operation. Yeah.
Dariush, we're really grateful for your time,
Cool.
and
Nice.
looking forward to getting this out there.
Anton, that was a very varied and comprehensive discussion. What were your key takeaways?
Yeah, absolutely. I think it's a great topic for us to discuss because deep flap reconstruction is one of the most highly performed procedures across plastic surgery, and I actually think that the donor site morbidity is the key to obviously patient satisfaction, which is the first thing we're after, beyond the actual reconstruction itself. And then secondly, from a health economics perspective, that's one of the keys of helping the patients leave the hospitals earlier, which is in turn going to make this procedure more available, more supported by health systems, and more available to patients. So, anything that improves that. And I also believe that, abdominal complications are probably underreported, possibly for obvious reasons. And this technique that Dariush has described, and he mentioned Dr. Boutros and other groups, and he mentioned Dr. Selber and some of the robotic groups, but this sort of minimizing the damage to the anterior abdominal wall is a key component to that. And you made a comment about is 4, 5, 6 centimeters, is that a huge difference? Well, I think some surgeons, some older teaching, people were opening the fascia almost completely, so this is a total transformation from that, and a great improvement that probably all DIEP surgeons should be aspiring to.
And as you say, it's not just about the length of the incision, it's about also being careful of the nerves and not denervating the entire rectus.
Absolutely. So I think, an important topic and richly discussed.
Well, thank you very much.
Thanks so much for listening. I hope you enjoyed listening to that podcast as much as we enjoyed recording it. And please like, subscribe, leave us a review, and consider submitting your research to the Journal of Plastic, Reconstructive and Aesthetic Surgery.
So until next time, the rest is plastics.